Facebook Live land. I'm so glad you could join us today. Welcome back for the Friday edition. I'm Mike Ackerman. I have the privilege of serving as president of the board of the Sudden Arrhythmia Death Syndrome Foundation, and I'm a genetic cardiologist here at Mayo Clinic. And on behalf of Alice Laura, the CEO of the SADS Foundation, thanks a lot, everyone, for choosing to spend your Friday afternoon or out in Spain, your Friday evening on what is a very special day in Spain, Family Day. I mentioned Spain because I'm really, really grateful and excited to have a dear friend of mine, a genetic cardiologist and channelopathy, cardiomyopathy specialist joining me, Dr. Sarquella Brugada from Barcelona, Spain. So welcome to the program, Georgia. How are you over there?
I'm fine, thanks, Mike, and welcome everybody. And very glad to be here and spend the evening with you, part of the evening with you, and also joining this special family day for us as well.
Well, I know we've had over 35,000 views joining us over these several Fridays for the past 8 weeks now that we've been doing this. And I know tonight over in Spain, we have several families with SADS conditions from Spain who have jumped in to join us. And so all I can say, Georgia, is ¿Cómo estás to them? So why don't you go ahead, why don't you give a greeting to all of our friends and families and your patients in Spain who have decided to join us?
Bueno, muchas gracias y encantadísima de estar aquí con vosotros. Vamos a dar la charla en inglés, pero seguro que vamos a poder cambiar a español en algún momento. Y gracias por estar aquí, todos los pacientes. Thank you very much.
Yeah, muchas gracias. So we're starting to have questions come in, and Ellie says hello from Dublin, and I love Dublin. As you know, I've been there once, but as most of us, Georgia and myself and all of the rest of us, we haven't been too many places for the last 2 months. I was telling Georgia before we came on, I've been home since February 29 was my last flight. And so we are in the COVID-19 pandemic. I don't think that's a news story for anybody joining us. I just saw today, Georgia, that we've crossed 4.5 million cases. Sadly, we've crossed 305,000 deaths attributed to SARS-CoV-2 COVID-19. Here in the United States, we've had over 1.4 million cases and over 86,000 deaths. Our country, as you know, is 328 million. My dear friends in Spain have been hit particularly hard. They have had over 230,000 cases and over 27,000 deaths for their country of 47 million. Right in my backyard here in Olmsted County, thankfully, we have not seen the peak. We have been a steady trickle over these 8 weeks where we're now at 417 cases and thankfully only 9 COVID deaths. So that's the current stats, if anybody wanted to know them. But Georgia, before we start entertaining the questions from our friends who've joined us, what's it like right now from the standpoint of the pandemic in your country?
Well, the thing is that we've gone out of the big peak, which has been really hard and harmful for the country and the health system, of course. And now we are starting relaxing a little bit all the measures that were imposed by the government to try to cut down this peak. The thing is that the relaxation makes that people maybe it's taking less care of what we should do. And we are seeing a little bit of a peak now, or what we could see like an increase of number of cases again. And of course, adding to that is that the number of strange cases that we are seeing in children that we have not seen up so far, that we have seen some rare presentations of COVID-related general manifestations, not only respiratory that we don't really see in children, but we are seeing other presentations. And we are dealing with that, which is also worldwide, and I'm sure that also here in the States, Mike, you are seeing that. But it's really like what is going on, and we are aware of that.
Right. About 8 weeks ago, when things really started to hit, we had a tremendous amount of anxiety, I think, in our SADS families, because we had the paper come out, remember, of if you have heart disease, you are at high risk of bad COVID-19. And our families were starting to call in and say, is long QT syndrome heart disease? Is Brugada syndrome heart disease? And we had to sort of talk them down and reassure them that that's not the heart disease of risk, and our families are not at increased risk. And I'm wondering, with the families that have been calling into your program, what have been sort of the 2 or 3 most important messages that you've been giving your SADS families over these last 8 weeks?
Well, the thing is that keep calm. That's the first one. That these heart diseases, as you say, these heart diseases that we hear on the news are not the ones related to channelopathies, cardiomyopathies. The fact is that keep calm, wash your hands, keep your social distance. In fact, be a normal person, as what we want you to be. And of course, there are certain conditions like Brugada syndrome that if you have fever, you have to be aware of that, but not fever because of COVID, it's fever of whatever reason. And that's what we are trying to transmit to our families, that don't upgrade the level of anxiety because of that, because this is not the type of disease you are more in danger of. So that was the message.
Now, I noticed, Georgia, you mentioned Brugada syndrome, which some people may not have heard me at the beginning, that your maiden name is Brugada. Tell our listeners a little bit about the most beautiful Brugada family member. Who is this on the other end of the phone with me? Georgia Sarquella Brugada. Tell our audience a little bit about yourself and your program.
Well, in fact, I'm the pediatric representation of the family. I'm the only one that started doing pediatrics. I'm a pediatrician myself, and then I went to pediatric cardiology and genetic cardiology, which is, as you know, Mike, it is my passion. And of course, belonging to a family which is called Brugada, it makes you go through a path which, of course, I go happily there, but taking care of the families is my big motivation, and I think that has made us the family Brugada to be as a whole in this type of diseases, and to take more the pediatric part, but also the following up of all the patients with inherited cardiac diseases as well. In Barcelona, in Hospital Sant Joan de Déu, where I belong, it's the biggest pediatric hospital in Spain. We take care of children with inherited cardiac diseases. We are the national reference center for that, and also we are the coordinators of the pediatric part of the European reference networks in rare cardiac diseases as well. So we try to cope with, to give the care for our families with inherited cardiac diseases. And of course, I have good friends like Mike that help us also for some tough cases to work as a whole and a group, which I really appreciate.
Well, it's just great having you, Georgia. Well, our audience and our SADS Facebook Live community, they're starting to engage us with some questions. So keep the questions coming. I like what you've done. You're learning out there. You're making your questions very short for me as I glance over to read them. So Ellie from Dublin is asking us that she has type 2 long QT syndrome, and she's wondering, are they at high risk of getting COVID-19 at any time? You want to speak a little bit about what is the relative risk of our channelopathy patients in terms of them getting infected and having significant COVID-19 disease, Georgia?
Well, in fact, for long QT, we know that the big deal with that is that all the drugs that have been tried to be used for COVID are QT prolonging drugs. So it's not a matter of the disease on a long QT patient. It's a matter of the treatment that we are giving to treat the COVID that might affect long QT patients. And that's the most important part.
Yeah.
We have doubts, right, Mike? We have doubts about if the drugs really are useful for the treatment. And we have had a very recent publication on is it useless or not, the drugs that we have been trying so far. We don't really know. The thing is that if you have a long QT syndrome, like an already known long QT syndrome, we have to be aware that there are a list of drugs that we have to take care of. And you are more at risk because you are receiving a drug that prolongs even more your QT interval.
Yeah. And I think that's the important message, isn't it? That our long QT patients aren't at any greater risk of getting the disease than my daughter or sons or your beautiful daughters. It's just that if they do get it, the doctors need to be really careful about what they're choosing to treat. And we tell all of our families, you cannot be started on the so-called Corona cocktail of hydroxychloroquine or azithromycin without my explicit permission. Because those medicines are potentially QT deadly in a long QT patient. So the disease, no big deal, no different risk, but the treatment, should they get it, is a different story where you and I need to make sure that the treating physician has included us in the discussion quite carefully. Speaking of treatments, Rocio, about remdesivir and whether that affects the long QT. And you mentioned that many of the possible COVID-19 therapies are potentially QT agitating, but maybe not with remdesivir. What do you think about that drug? Are you guys using that in Spain right now?
Yes, we have been using it for certain cases which were not going that well. So in fact, it's like what you give after so many other things. And of course, these are these severe cases. So how much part of that is because the disease was really severe, or how much part is the drug is not working well, or maybe it does. So has been many ups and downs on that, and there are plenty of clinical trials. But of course, we are working on the field with results that will come up in maybe a month. So it's very difficult to know at which point we are in the right position, of course.
Right. And I know this one violates my rule of being a short question, but GT is asking a really good question. George, I'll summarize it. He or she is aware of what we publish and has seen our international compendium paper about reappraisal of long QT genes. And he's wondering specifically that they've been told that they have type 5 long QT syndrome. And since the gene KCNE1 is a little bit under question, what does that mean for these families who are told they are LQT5? That's a tough one to unpack in a 30-second soundbite, but any guidance you would give, GT, on that one?
Well, I really think that what we would do, and I'm sure you would do the same, what we would do in any of our patients is that if your life depends on a drug that maybe prolongs your QT, just then follow your QT while receiving this drug, because you will probably die because of the disease you need to treat rather than dying for long QT. You are not going to be given a drug and sent home if you have something that prolongs your QT and if you already have a prolonged QT interval. But, and of course, we have to balance everything. And if you need to receive a medicine that you need it, of course, you need it. And then do something to really monitor to make sure that you are not in a big risk at home alone without any type of monitoring.
Yeah. Right? Yeah. I think that's really important for GT. And I think the other thing for them and the long QT5 families out there is that LQT5 is a real monogenetic disease. It's a weaker one overall, and all the variants in that gene, KCNE1, aren't created the same. So some, Georgia and I know, are LQT5 causative variants, and others are now kind of getting weaker and weaker and wimpier. And I think you just need to have you and your healthcare team take reevaluation of how strong was the clinical evidence in the first place to call you long QT to begin with, and really do the detective work to say, are we still going to charge this variant guilty as charged, or do we need to back off and say, in light of new evidence, maybe not so fast? And I think that's something that long QT specialty centers like ours at Mayo Clinic and like George's in Barcelona, that's what we do all the time. And you're probably doing that more and more these days, huh, Georgia?
Yes, of course. But I have to say that my families have been quite healthy, and it's good to show a little bit of tranquility, to calm down, because we have had one case that we had to admit at the hospital because of the channelopathy, and having that child had underneath and having fever, but that's it. So things go okay. So don't stress, and it's going to be fine. That's my message. My big message in that.
Yeah. Let's shift from long QT to CPVT. Alexandra is wondering, just in general, what could be the reason for quote unquote CPVT if her DNA or her genetic test has come back negative?
So coming from where?
She's
Mike?
wondering what could be the reason. So in other words, you and I diagnose somebody as having CPVT.
Okay.
We know we're right about our clinical diagnosis, and yet we order the CPVT genetic test and it comes back negative. Maybe tell Alexandra what might be the reasons for that negative result.
Well, we don't know everything, and genetics don't have the answer for absolutely everything. It's not bad, the number of positive results, genetic results we have on CPVT, but it's not 100%. So it means that there is a certain percentage of patients that really we can tell you have CPVT because your exercise test tells us so, and what we see, the type of arrhythmias we see on the tests that we perform makes us think that they work as CPVT, but there is no evidence, genetic evidence now on 2020, to know which is the gene related to that. Maybe the gene is yet to be known, and we need to explore it a lot. So there are certain families that we know they have it, but we cannot tell this is the genetic reason why you have it.
Right. And I think for Alexandra, we know, Alexandra, that if Georgia and I know that you have CPVT, the test comes back positive about 2/3 of the time. So overall, it's a really good genetic test.
Yes.
And we're busy. If you are negative in your genetic test, there's research programs like mine and hers where we try to find your family's unique reason. One thing I think is important to say, though, is the CPVT #1 gene, which is a gene called RYR2, that gene often comes back to Georgia and I ambiguous, where it says we found something in it, but we, the genetic test company, are calling it a variant of uncertain significance. And I think this is where a lot of sloppiness has happened out there. I just saw a patient yesterday, face to face or mask to mask, and I knew I had diagnosed her a couple weeks ago as having CPVT. The test came back RYR2 VUS, and they and the local team thought they were stuck with this ambiguous result. And I had to re-educate and say, the genetic test company, had to call it uncertain, but we, the phenotypers, we don't. And that for her is not an uncertain variant. That is a definite. And again, this is what your genetic heart rhythm specialty teams should be doing. We get a result. we see and read what the company said about it, but then we have to do our own analytics to see if we agree with how that variant was graded. And I'm sure you've seen a lot of these, right, Georgia, where it comes saying this is ambiguous, and you look at it and you say, wait a second, it's not
at all.
This is your family's cause.
That's it. And then it's when we call friends and see, oh, do you have a family having this ambiguous thing, which is not ambiguous at all, having the same mutation or the same genetic variant.
And I think this ties in with what Missy's asking us, Georgia. She's saying that she and her son have genes of unknown variant, but they both have syncope. Does this mean we do not have Brugada and we do not have long QT? So tell our listeners a little bit about how the chain reaction needs to start with the clinical evaluation first and foremost, and then start thinking about what the genetic test did or did not tell us.
The thing is that this comes, this we can see different schools. The ones that we have started doing clinics without having genetic tests available because they were either expensive, either unreachable, we had to do doing clinics, like seeing the patients, seeing what were the symptoms, seeing the ECGs, the exercise tests, the echoes, or maybe drug tests or provocative tests. And then we could have a genetic result. At the very beginning, we were asking for one gene or so. So we would say, oh, it matches what I've seen, or it does not match. But then if it does not match, I forget about the result.
Yeah.
Now, I wouldn't say the problem, but I say the problem is that genetic testing is so easy to reach, and it's so inexpensive compared to what it was before, that we just say, oh, I have felt dizzy, and I'm asking for a genetic test. And then I don't know what's the meaning of that result.
Right.
And that's the real truth. And in fact, that's a very nice sentence, quote from Claude Bernard, which was one of the biggest physiologists many centuries ago, which says that who does not know what is looking for does not understand what he found. Yeah. So, and that's very important, that we don't treat a genetic result, we treat a patient with the overall tests and symptoms, and of course the results that we have gone through.
That's great, Georgia. Since it's only appropriate as a Brugada family member to turn to Christine's question, and she's wondering, are you continuing to advise to stay home and manage fevers instead of going to the emergency department with their Brugada? Some hospitals have very low patient volumes. So talk to our listeners a little bit about Brugada syndrome and why we even tell them to be diligent about fevers anyway, and what is your Brugada fever drill that you advise your families?
Well, I'm a very relaxed person concerning Brugada syndrome, and you know that, Mike. And I think that's the feeling my families have also. That if, in fact, if you can, the risk might be fever, okay, but if you can control fever and you can have your fever treatment like paracetamol or ibuprofen, and it works well, then you are receiving already your treatment just to avoid fever. Of course, I would advise the patient, as always, COVID or not COVID era, just to go to emergency department when you cannot control fever, because that's the bad moment. But of course, we don't need to panic. I have seen many patients that just because they have Brugada, they are admitted to hospital every time they have fever.
Yeah.
That makes the big things very big. And it's not big. I mean, many of the patients with Brugada syndrome are patients that are going to go well. And just if they just control fever avoid drugs which are listed in the sodium channel blocking drugs, and that's it. And everything is going to be fine.
Yeah,
So,
it's interesting because I never told our febrile Brugada patients to run to the emergency department, and so my message didn't have to change with COVID-19. It's been the same as yours, George, is take care of the fever, and if you can't, then maybe go in, but you don't need to run in to get an ECG at fever. Sometimes we've done it more of, okay, I'm not seeing the Brugada pattern at rest, so maybe a first fever, let's get one just out of curiosity to see if fever is capable of bringing out the Brugada pattern, but not as a want 5-star alarm that danger is lurking around the corner imminently.
yeah.
We're going to give Christine a bonus one because I think this is an important one. She gets 2 for 1 today. So it's your lucky day, Christine. Her Brugada son is 9, showed the pattern with fever. He was not advised to get a defibrillator or a loop recorder, whereas others she's heard of, they get those devices immediately. He's never had a faint, never had cardiac arrest. Do you recommend a watch and see approach? And I think this is getting at the question of, she's hearing people with Brugada getting defibrillators, easily and quickly. What would you want to tell her and her 9-year-old son about how maybe the message is actually the majority of people with Brugada don't ever need a defibrillator? What kind of things are you telling your families when you diagnose them with Brugada as whether a defibrillator is around the corner or may never need to happen?
So my message, and they know that we'll do everything to avoid defibrillator, okay? Knowing that there are certain patients that might need it because they have a severe pattern, they have a very bad family history, and they have a basal ECG, which is what we say ugly, or sometimes we say beautiful because we see the pattern so well. Those are the minors of the cases, and those are the exceptions. In general, having a normal ECG that just turns positive with fever, in fact, is like the provocative test. And that's a way where we say, yes, of course, they have Brugada, but controlling fever, you don't have the pattern, meaning that's going to be okay. Of course, there are some kind of things that sometimes we want to see. What we have done, Mike, in some of our patients is that when I have received, and I'm sure you have already seen patients that they come for second opinions when they carry their ICD already. And they come to you asking, I'm okay, have I been correctly diagnosed? And they already carry the IRCD. So it's very difficult to take an ICD out. Not technically, which it can be difficult, but not that much. It's who takes the decision of taking an ICD out. And that's a big thing. The thing is that sometimes we implant a loop recorder in those patients having had symptoms or mild symptoms that we don't really believe they come from the heart. But we know that if someone sees a patient having a Brugada syndrome that has a moment of dizziness or maybe a faint, they will implant an ICD. Before implanting an ICD, we have to be really sure that that child or that patient is an ICD. And sometimes it's when we implant the loop recorder, because in fact, we want to rule out or to make sure that those patients don't have cardiac reasons to implant an ICD, right?
Thanks, Georgia. That's perfect. I'm going to welcome Katrine from Germany. That's a couple from Germany. So I took 1 semester of German. I still remember, was machst du heute Abend? Ins Kino? So that means, what are you going to do tonight? Go to the movie? So that's the extent of my German. Otherwise, tschüss. I remember that one too, Katrin. But I'll quickly take Valdone's. I like it, and so I'll answer it quickly. What kind of sport is possible for an 11-year-old kid with type 1 long QT, never a symptom, no family history, inherited it from his dad, who's 37, and also asymptomatic? That answer, Katrina, Valdone, is it depends on who you're seeing. If you're seeing somebody like me in Georgia, your child can dream big and can virtually do almost anything and everything his heart desires. If you're seeing somebody else, perhaps they've told your child to be a couch potato and never get his heart rate above 70 and don't eat chocolate. And so I think it really depends. We have learned and we've published that our long QT families can absolutely live and thrive big time doing almost everything that my children got to dream to do and George's daughters got to dream to do and are doing. So it's a new day. It's very different than the way it used to be 20 years ago. Are Georgia and I still in the minority a little bit? Maybe.
Yeah.
This minority view is growing as the evidence is proving what we've been saying for over 20 years, that these kids can live large. I'm going to turn to one that we haven't talked about over the last 8 weeks. And you mentioned it, Georgia, at the beginning of the program, this pediatric version of COVID-19. And Janine is asking, does this COVID-related pediatric inflammation disorder pose more of a threat if I have long QT? And so for those out there, what Janine is referring to is something that was observed earlier in Europe, and now we've started to observe it in the United States. And we, in fact, in the US, it's now called MIS, I think, multi-system inflammatory syndrome, that kind of mimics, in some ways.
Great.
But do you think if a child shows that version of COVID-19, that's going to be a bigger deal if you have long QT or Brugada or CPVT or anything else? Because you guys know more about that condition or that expression of coronavirus in kids than I think we do yet in the States. What are you observing and learning, Georgia?
Well, we are working with people at the Mayo Clinic as well. We are doing we have been working on an international registry on this, and there are some patients from Mayo included as well, some from New York, but also from Pakistan, from UK and Spain. And we put together 40 cases related on that, and we have seen that there were no channelopathy children there except one patient with Brugada. And the thing is the same, just the fact is the fever. And all these things related to fever we need to, of course, we have to be careful with Brugada as well. But there is this inflammation, and that won't really go with that. The treatment that these children need are the treatment for either cardiogenic shock or either inflammatory disease, which can be used with any type of channelopathy. So once again, you are not more at risk because of this inflammatory presentation in children, and first of all, and second of all, those patients are certainly affecting the whole type of children, not only disease related. So having a long QT, a Brugada, CPVT, or any type of cardiomyopathies will not differ on the way they present.
Great. And I'm going to give you, Georgia, the last question from Crystal. So Crystal, you win the prize. There were a couple other ones that came in. So join us again next Friday. We'll pick up on them. And it's this from Crystal. Her 5-year-old has had 3 nighttime tonic-clonic seizure-like episodes, and she's tested. All testing has been normal except for having some variant in KCNH2. And how much faith would you and I put in 2 quick ECGs that have been quote unquote fine? He has an MRI scheduled in a couple weeks, and Crystal, the mom, is feeling panicked as she's getting the impression that the doctors are ignoring the genetic finding because of the ECG results. So that's probably a long answer of needing to do a major timeout and really look at all of the pieces of evidence. But what would be the next steps, Georgia, that you would encourage Crystal with? And besides telling her first, don't panic, it's going to all work out.
That's the first one and most important. Second of all, there are many presentations that have to be taken into account. But once again, we are not treating a genetic variant. Of course, if we have the doubt on lung QT, not only a basal ECG is the answer, and we may have this kind of position like to lay down and put the patient down, maybe exercise test. Even at 5-year-old, you can do an exercise test. Of course, it's not going to be the normal one, but you can do Holter's ECGs and make them run to see how does it move. And of course, you can test ECG dad and mom, which sometimes gives you the answer. And of course, you have to go and maybe see a specialist on lung QT, which is which will help you much better, because this is a rare disease, and we need people who is really used to see rare diseases, right, Mike?
Yeah. Well, Georgia, it's been wonderful to have you join us for this session. I can't believe we've already come to the top of the hour almost. And so we're heading to a 9 p.m. evening getaway for you and your family for the rest of a special holiday in Spain, a family day. So happy family day to you and to your daughters and to your husband. And thanks for joining us. Anything you want to just leave as final thoughts for our SADS families and potentially physicians and anybody who's joined us out there? Last words from Georgia.
Well, just enjoy your evening, of course. Enjoy your day. Be safe. Wash your hands, which is very important. And do not panic. Everything is going to be okay. And we're all going to be fine, really. Thank you, Mike, for being here.
Thanks, Georgia. And as many of you know out there, you've been watching my granddaughter grow up, and I think Georgia hasn't even seen her yet. So
no, wow.
So I got to see her last week. She's now 3.5 months old, everybody. And I'm going to get to see her again next weekend. So this 60 days of not seeing her is over. And like Georgia said, Jaden would like to say, be cool, everybody.
Way.
all going to be good. We have to do our part. As I've always said to you out there, the longer you all stay coronavirus free, and the longer that Georgia and I stay coronavirus free and our families, the better for all of us, because we're learning more and more every day. We're learning how to treat. We're learning how to coexist with it as communities are starting to open up again. And we're going to learn what's the wise and right way of coexisting with this virus, because it's not going away. It's going to be around for a while. And we're going to have to be in this coexistence. I love the part right now where our clinics open. I love the patients who I got to see. I can't wait till I get to see all of them, because so far, all I see is this. And so it is not quite the same when you don't see their face and their smile or the look. And so I'm looking forward to the day when we get rid of the mask. But right now in our clinic and in Georgia's clinics and in most clinics throughout the world, it's kind of a I mask, you mask, we all mask together. And I guess we'll just do it that way until we all get enough confidence that maybe we can see each other's expressions again and not have to worry about what if one of us is an asymptomatic shedder and we didn't know it. So until then, do all the things Dr. Brugada told you to do, and join us again next Friday. If you haven't filled out the SADS Foundation survey, remember we sent out surveys about, have you had coronavirus infection and you didn't let the long QT or the channelopathy specialty center know because you're navigating just fine? Because I'm still not aware of a single long QT family who's had a significant COVID-19 disease expression. And so it's really uncommon out there, and let's keep it that way. But fill out the survey, let us know, and join us again next Friday, same time and same channel. Until then, blessings, everyone. And to those in Spain, blessed Family Day. Thanks, Georgia. Thanks, everyone.
Thank you.